from this aspect. So think of diseases that you think of, for example, relapsing polychondritis or lupus. Think of that. This will be the one that hopefully will be discussed by Dr. Ketter. Sunday, welcome back.
Great, thank you very much. And thanks for the wonderful introduction, Kwan. And again, the opportunity to speak today. This has really been a pleasure to speak at this course last year and this year. So today I wanted to discuss the ocular manifestations of select autoimmune diseases. Some of these, all of these diseases will have manifestations both outside of the eye as well as the eye. Some of these are conditions for which you're more familiar with the names, and some maybe will be new to you if you're new to ophthalmology. I'd like to take this as a case-based approach. Given the limits in time, we won't have enough time to be a completist about all manifestations of systemic autoimmune diseases in the eye, but we'll try to take a select few and discuss them as cases. All right, so our first case here, this is a 46-year-old woman who complained of sequential blurring of vision, right eye, then left eye, following 2 days of headaches and alterations in her hearing. She complained that everyone sounded like they were underwater and noted a moderate headache as well as light sensitivity. On examination, she had bilateral serous retinal detachments with anterior uveitis and mild vitritis. Fluorescein angiogram, as you can see here on the right, revealed numerous punctate hyperfluorescent foci in the early phase, with progressive pooling of the dye in the areas of retinal detachment in the late phases. Although her findings were most consistent with VKH, Vogt-Koyanagi-Harada Syndrome, she underwent a workup for associated systemic disease that was performed. This was negative, however. The Vogt-Koyanagi-Harada syndrome is a granulomatous inflammatory disorder. It affects the eyes, the auditory system, the meninges, and the skin. Although VKH has been known since antiquity, many details of the condition, including the exact cause as well as the most effective therapy, really remain unknown. The evidence suggests that it involves T lymphocyte-mediated autoimmune processes directed against an antigen associated with melanocytes. The triggering mechanism seems to be unknown, but sensitization to antigens from cutaneous injury or from viral infection have both been proposed as possible factors. There is a strong MHC class II associations, specifically HLA-DR1 and HLA-DR4. Although VKH tends to affect more races who are more darkly pigmented, and it's uncommon in Caucasians, but it's also uncommon in sub-Saharan Africans, suggesting that there may be other factors besides just the amount of pigmentation that are important in its pathogenesis. So it's important to remember that multiple organ systems may be involved. The clinical course generally follows 4 phases, or we've divided the clinical course into 4 phases. Prodromal, an acute uveitic phase, convalescent phase, and the chronic recurrent phase. So in the prodromal stage, patients will usually experience, possibly will experience flu-like symptoms, headache, meningismus, tinnitus, and dysaceusia. They may also experience orbital pain and scalp and skin hypersensitivity. CSF lymphocytic pleocytosis occurs in about 80% and can last for about 8 weeks. Although for many of these patients, lumbar puncture and CSF analysis is not performed. Central dysaceusia, involving the higher frequency, occurs in about 30% of these patients, and it usually resolves after several months, but it may remain. In the acute uveitic stage, this is heralded by the onset of sequential blurring of the vision in both eyes, 1 to 2 days after the onset of CNS signs. The focal serous retinal detachments may start in a cloverleaf pattern around the posterior pole, but they may also expand into large bullous exudative detachments, as we had seen in our patient at the beginning. The anterior chamber may shallow due to forward displacement of the lens iris diaphragm due to ciliary body edema or annular choroidal detachment. So again, this is one of those cases, and this occurs uncommonly, but I have seen it several times over my career thus far, of patients that are assumed to have angle closure glaucoma and a laser peripheral iridotomy is performed without much success because most of the problem here is forward rotation of the lens iris diaphragm. This is an OCT photograph here where you can see subretinal fluid. But one other thing that distinguishes this from perhaps central serous chorioretinopathy is if you look all the way at the lower photograph here, just the arrow to your left, you'll see that there's actually fibrin there in the subretinal space, which is uncommon in central serous retinopathy. In addition, you'll see some irregularity to the choroid or choroidal folding, which again is more significant for VKH than central serous. ICG angiography may show hypocyanescent spots, and here you also similarly see that clover leaf type pattern of the subretinal fluid around the optic nerve. As the disease progresses, patients with VKH may experience an improvement in the uveitis and progressive depigmentation of the choroid and the skin. Remember that the vitiligo and alopecia typically follow the uveitis or the initial episode of uveitis. Here you see depigmentation of that first patient that I showed you. And you can see evidence of poliosis here. The eyelashes have turned white. There is evidence of vitiligo as well along the forehead and as well demonstrated on her forearms and back. The final stage of VKH is characterized by recurrent anterior uveitis. In this phase, posterior uveitis is rare, but not impossible or not extremely uncommon. The inflammation may become steroid dependent or resistant at this stage. So it's important, the full diagnostic criteria will be iterated in the handout, but it's important, the important issues to remember here are that there should not be a history of ocular trauma or surgery preceding the uveitis. And the reason for that is because there may be overlap with in the findings with sympathetic ophthalmia. In addition, there generally are no evidence of other systemic diseases. Patients with melanoma and certain immune checkpoint inhibitors used for the treatment of cancer may create a phenotype that resembles VKH. In addition, patients generally have bilateral ocular involvement. And as I said before, the integumentary findings, the skin and hair changes generally don't precede the uveitis or should not precede uveitis. In terms of treatment, there are a variety of ways in which to treat these patients. However, I think it's important to be as aggressive as possible up front. Systemic steroids, especially IV solumedrol, can be very helpful at getting the disease under control quickly. Sometimes patients are placed on oral steroids of doses of 80 or 100 milligrams, and that can be effective, but generally IV solumedrol seems to get it under control the fastest in my experience. We recommend a slow taper of oral steroids, generally keep patients on low dose steroids for a period to complete 6 months of treatment. It doesn't mean you complete the patient on or keep the patient on 60, 50, or 40 or high dose steroids for that entire time. But generally, once you can get them down to 10 milligrams, we try not to reduce that until they've reached that 6-month mark. Immunomodulatory therapy may be of great benefit, especially in earlier intervention and reducing the progression towards sunset glow fundus and severe vision loss. So we'll continue on to this next patient. This is a 60-year-old gentleman from Spain who was referred to me for a 3-week history of redness, pain with left gaze, and tenderness to palpation in his left eye. He had been treated with QID, daily prednisolone acetate, with minimal improvement in his signs and symptoms. On examination, he was noted to have injection from approximately 10 o'clock to 3 o'clock that did not blanch with phenylephrine, tenderness to palpation superiorly, as well as over the lateral rectus muscle. You see some injection here. The patient's treatment was changed to difluprednate at that time to try and avoid use of systemic medication that might upset his GI issues. And a workup for associated systemic disease was initiated, which revealed I'll show you here, sorry, this is a red-free slit lamp examination of those same red vessels. A lot of time using the red-free filter will allow you to distinguish between injection of deeper vessels versus conjunctival or episcleral vessels. So the patient was revealed to have a positive proteinase 3 ANCA and elevated serum creatinine as well as microscopic hematuria. So the patient was diagnosed with scleritis and myositis associated with granulomatosis with polyangiitis. And after consultation with his gastroenterologist, his treatment was changed to oral prednisone with good response of his ocular and systemic symptoms. He was subsequently started on intravenous rituximab, and his inflammation remained controlled now approximately 2 years later. So granulomatosis with polyangiitis is a multi-system disorder which can often involve pulmonary vasculitis, glomerulonephritis, and small vessel vasculitis. In general, the sinuses tend to be more involved or more commonly involved than pulmonary or renal complications. 85% of these patients may develop glomerulonephritis, and there's a high mortality rate. The 1-year mortality rate without treatment is approximately 80%. Ocular involvement occurs in about 15% at presentation and about 50% over the course of their disease. 10% of these patients will experience uveitis. Always make sure to check ANCAs specifically and include, you may also need to include specifically checking for myeloperoxidase and PR3 antibody subsets, as it's not always checked in cases in every lab with ANCA, so you must make sure to request it in cases of scleritis. And the reason for that is because there is a risk of this being glomerulonephritis with polyangiitis, and there's such a high mortality or high risk associated with these patients that getting them on treatment is of vital importance. The ophthalmologist can really play a key role here in saving the patient's life. Our third case is a 33-year-old woman with a history of fever, productive cough, and headache. And on examination, she was noted to have anterior uveitis in both eyes, but more significantly in her left eye, she was noted to have several nodules, including these large Kepi nodules, as well as the Busaka nodules. The Kepi nodules are located at the pupillary border here, and the Busaka nodules on the iris stroma. In this case, the patient was diagnosed with sarcoidosis. Remember that sarcoidosis is always in the differential for patients with uveitis. And while most of these patients will have an anterior uveitis, about 85% versus 25% patients having posterior uveitis, and 10% having both, it can be an insidious chronic bilateral disease, and that's not at all uncommon. As you will recall from the lecture yesterday, these patients may experience progressive decrease in vision or progressive increasing injection or redness to their eyes. They may also experience floaters, flashes, but may not have the same acute symptoms that a patient with HLA-B27 associated uveitis has. Many of these patients will have mutton fat keratotic precipitates, but realistically, sarcoid uveitis can present in any form. In this case here, we can see that the patient has enlargement of the lacrimal gland, and a biopsy of that lacrimal gland can prove fruitful in terms of making the diagnosis. So you always want to check not only the intraocular examination, but also the extraocular examination, and specifically looking under the lids of both the upper and the lower lids. And I'll get into a little bit more detail about that in a second. Gonioscopy can be very helpful here. There are nodules known as Berlin nodules, which usually exist within the angle. And those, many people believe that those are more specific for sarcoid uveitis. There is also a condition under which patients with sarcoid uveitis will develop inferior mutton fat precipitates and corneal edema overlying that area due to endothelial dysfunction or damage to the corneal endothelium. And this may be referred to as the inferior prismatic effect. Again, these are demonstrations of both the Kepi nodules and the Busaka nodules, as we have described before. Patients with sarcoidosis may also develop band keratopathy, not only due to the chronic inflammation in the eye, but also due to elevated levels of serum calcium. This is an example of a patient with severe band keratopathy and ciliary flush. In some cases, these patients, it may be difficult to assess how active the inflammation is, and ciliary flush can be a good indicator that the inflammation is not under complete control. In this patient, there was an optic nerve granuloma. Patients with sarcoid uveitis may have optic nerve involvement. In general, I found compared to other uveitic conditions with optic neuritis or optic nerve inflammation, sarcoid uveitis seems to respond very well to steroids. And in my experience, again, the visual recovery has been much better than other conditions. In this patient, we see an area of retinal periphlebitis, which again is also not uncommon in patients with sarcoidosis, and posterior segment involvement. These are the classic candle wax drippings, and as well as nodular granuloma, forming nodular granulomas along the venules here, as well as a perivasculitis. So one of the key points that was made to me during my fellowship, and I think I tried to impart with the residents and the fellows here, is that sarcoidosis may oftentimes be asymptomatic. So patients don't necessarily have to have shortness of breath, cough, fatigue, or other systemic findings. And this makes it important to check for sarcoidosis in almost all patients that come through with an undiagnosed uveitis, because they may be asymptomatic but have findings consistent with sarcoidosis. Again, generally, the chest symptoms are slightly more common than eye symptoms. Patients may also present with two specific syndromes. One is called Herford syndrome, which includes uveitis, parotitis, fever, and facial nerve palsy. The seventh cranial nerve is the most common cranial nerve involvement with sarcoidosis. So keep that in mind also when you're taking a history of patients that present to you for uveitis. If they've had a history of facial nerve palsy, that might also cause the light bulb in your head to go off and to think about sarcoidosis and to work that patient up a little more aggressively for sarcoid in that case. Lofgren syndrome is characterized by erythema nodosum, febrile arthropathy, and hilar lymphadenopathy, as well as acute iritis. Diagnosis of sarcoidosis is really based on tissue biopsy, all right? And so oftentimes we may not be able to get a tissue sample, but we should make every effort to look to see if there is something to be biopsied, whether that's the lacrimal gland or perhaps the conjunctiva. This was a patient that was referred after a couple of years for an optic neuropathy as well as uveitis, and the patient had not had any diagnosis at that time. When we looked at the palpebral conjunctiva, we were able to find several nodules there that when biopsied revealed non-caseating granulomas. And while the chest x-ray is, in addition, there we can apply chest radiography or serologic testing, and while the chest x-ray or chest CT scan may be more likely sensitive than serologies, as I mentioned yesterday, an ACE lysozyme or serum interleukin-2 receptor can be helpful as adjuncts in the diagnosis. But remember that an ACE is neither sensitive nor specific and may not be elevated in sarcoid uveitis. So a negative test does not rule out sarcoidosis. And in fact, even a negative chest x-ray and a negative radiography, in my mind, can't rule out sarcoidosis, as there can be fluctuations in the appearance of these findings over the patient's lifetime. And so we may be catching them at a time when those symptoms or those findings are minimalized. So I'll move on to our next case. This is a 30-year-old Caucasian woman with a history of missing spots in her vision. And as you can see here by the fundus photo, there are a number of cotton wool spots. We see several areas of hemorrhage, specifically around blood vessels. And we see a similar pattern here in her left eye. When we perform angiography, you can actually see several areas here where there's almost an obliterative vasculitis with pruning of the vessels, and there's large areas of capillary dropout temporally as well as within the macula. Here's a closer photo here. And if we look at the OCT findings, we can see that there's disruption in the inner retina on both the right and the left eyes with multiple levels. And this would be a patient that had a similar process or a similar disease underlying who developed hypopia and uveitis. One thing we notice here is that the eye is relatively white and quiet, despite the fact that there is a fairly large hypopia in there. This can be characteristic of patients with Adamantiatis Behcet's disease, which is what our patient had here. So our patient was Behcet's disease is a chronic relapsing multisystem disorder, and it can involve almost any organ and affect a variety of ethnic populations. The disease is relatively rare in the United States, affects approximately 50 and 100,000 patients, but certainly since it is very dependent on geography within the US, I've certainly seen more cases since relocating here to California than I did when I was on the East Coast in New York, and I think that has to do with the local community or my referral base here in Southern California. The diagnosis is clinical, and testing such as pathogy testing and HLA-B51 testing lack sensitivity and specificity, but can be helpful as adjuncts, as I mentioned before, but may have little value in specifically ruling out or ruling in the diagnosis. There are several criteria suggested to diagnose Behcet's disease. I prefer to use the IUSG Behcet disease as criterion as it's simpler. Oral ulcers are the most frequent finding, characterized by discrete white lesions with red rims. These generally last about 7 to 10 days, and they're typically about 2 to 15 millimeters in size and heal without scarring. Genital ulcers are similar, but these do tend to scar. And these criteria will be replicated in the handout. Systemic involvement in Behcet disease is predominantly arthritis, but can also encompass systemic vasculitis, cardiac, gastrointestinal, and pulmonary findings, and neurologic findings. About 30% of patients with ocular Behcet disease will have neurologic findings. Hypopian uveitis or uveitis may affect a majority of Behcet's disease patients. About 80% are bilateral. Typically, patients will have necrotizing obliterative vasculitis within the uvea. As I mentioned, hypopian can be characteristic of patients with Behcet's disease uveitis. In the US, about 80% of patients with hypopian uveitis will be HLA-B27 positive. So in your differential diagnosis of patients that do have a hypopian, you certainly have to consider HLA-B27 uveitis, infections, especially if they've had recent surgery or recent procedures. and then Behcet's disease. In the hypopyon with Behcet's disease, the patients, as I mentioned, can have a white or quiet eye. But what's interesting also is that the hypopyon may shift with changes in head position and disperse very quickly with quick movements of the eye. This is a little bit different than the hypopyon that you'll typically see with endophthalmitis or with HLA-B27 associated uveitis. Posterior segment findings include an occlusive retinal vasculitis, as I mentioned before. It can affect both the veins and the retina, and the arteries, excuse me, and can be associated with a chalky white retinitis, as you're seeing here. Posterior panuveitis can occur in about 50 to 80% of Behcet's disease patients, Behcet's disease uveitis patients over their lifetime. So again, retinal ischemia, as occurred in our patient here, can lead to the development of neovascularization, which you can see more prominently here on the right and left. The persistence of peripheral ischemic changes, you should note the persistence of these retinal ischemic changes, as well as the pruning of the retinal vessels that occurred over time. She received pan-retinal photocoagulation to see whether this would alleviate the neovascularization, but because this persisted, we did end up injecting her with intravitreal anti-VEGF injections, which seemed to improve her condition over time, over a series of several injections. And for our final patient, this is an 11-year-old male with a years-long history of bilateral nongranulomatous iridocyclitis. And what we can see here is band keratopathy on the left eye. That's that sort of haziness just inferior to the pupil. You can see posterior synechia and the development of the cataract in the left eye. And the right eye, although on this photograph it looks much better, I can tell you that on examination there was an inflammation here on the right as well in the anterior chamber alone. So the patient had a history of both knee arthritis in both the knee and 2 of his ankles. In general, his iridocyclitis was controlled with topical steroids, but they caused elevated intraocular pressure. He had been treated with both methotrexate and cyclosporin, and currently was also on oral prednisone at that time. He had significantly diminished vision in his left eye. There was a trace afferent pupillary defect with borderline intraocular pressures. Likely this patient had progressive damage from glaucoma, but also was noted to have a significant cataract in the left eye, which was later removed. Juvenile idiopathic arthritis was the final diagnosis for this patient. It's the most common associated disorder with pediatric anterior uveitis. The incidence is about 2.2 to 2 to 14 cases per 10 to the 5th population per year. Prevalence is, again, 16 to 113 per 100,000 per population per year. And there are multiple classification criteria for this, and there are different names for it. I think more recently we've started to adopt JIA, or juvenile idiopathic arthritis, as our preferred nomenclature, and there are a number of subtypes that are described here. The important thing to note here is that there's a higher percentage of anterior uveitis in patients who have ANA positive disease, persistent oligoarthritis or extended oligoarthritis, than in ANA negative disease, although polyarthritis certainly does have a similar percentage of patients with anterior uveitis. So in the screening recommendations, and this is quite important, this generally comes up as a question on the boards each year, but we generally want to screen patients more frequently if they have certain criteria. So in patients who have oligoarthritis or polyarthritis and they're ANA positive, we definitely want to screen them at more frequent intervals of every 3 months. If they are, especially if the age of onset is less than 6 years old, and regardless of the disease duration. as the patients develop more systemic disease, what was formerly known as Still's disease, the likelihood of developing uveitis is low, and those patients can generally be followed every 12 months. One thing that we've noticed is that the number of ocular complications increases the longer the duration of uveitis. And so what this hits with this, the point that this makes, I think, is that patients are more likely to have progressive problems as they get older and as they've had the disease longer. And so it makes more sense to be aggressive and treat the patient for their inflammation at the outset. So as soon as they start developing inflammation, I think it's important to be aggressive, and you really should start thinking about immunosuppression at the beginning for these patients. If we look at uveitis, JIA-associated uveitis in terms of outcomes, we can see that our outcomes have improved greatly over years as we've incorporated the use of more aggressive immunosuppression for these patients and trying to rely less on topical or systemic steroids. You can see that the percentage of blindness has gone down, percentage of cataracts has gone down, and the percentage of patients with glaucoma likewise has gone down. In terms of the patients with glaucoma at 5 years of follow-up, we can see that the ANA positive patients are much higher than the ANA negative patients here. And again, that may be due to increased likelihood of uveitis. And finally, when we look at patients who achieve remission, what we find is that the proportion who remain free of remission, it decreases over time for more severe disease. So visual morbidity is common. The rate of blindness for these patients is about 10% per person year. The ocular complications are also common. About 2/3 of eyes at presentation will have ocular complications, and the rate occurs at about 0.4 per person year complications. Risk factors for complications include anterior chamber flare, posterior synechia, abnormal intraocular pressure, and prior surgery. So again, if the patient presents to you with these things, you might consider being more aggressive about controlled inflammation long term. Patients with cataract and band keratopathy are the most common, cataract and band keratopathy seem to be the most common causes of vision loss here. As I've mentioned a number of times in the last few minutes, we want to be aggressive about treatment. Certainly initially we'll be aggressive with topical corticosteroids. Chronic use of topical corticosteroids is, I think, controversial and varies among uveitis specialists. I personally favor the elimination of topical corticosteroids if at all possible. Some papers and specialists will tolerate use of less than 3 times a day because the rate of complications such as cataracts and glaucoma seem to be low or acceptable in those cases. But again, my own experience, and I believe Quan and Dr. Foster or some of the other physicians that are here can weigh in on their opinions with regards to chronic topical corticosteroids in these patients. We will generally try to use disease-modifying antiemetic drugs. Methotrexate was favored for a long time, but we now have biologic agents, and I believe the use of TNF inhibitors such as Humira and Remicade are often first line for these patients now. And with that, I'll end here. I think I've overextended my time by a few minutes, but thank you very much.
Sanjay, thank you very much for that. Very comprehensive. That covers some of the very important systemic disease that have ocular manifestation. I have been trying to answer and comment to all of our participants as fast as I could from the chat. But do we miss anything? If I have any question that I have not answered, please ask now or sort of later if you want. Clear any of those things. I think those are very important. Again, we at the colleague, the physician who care for patients with uveitis, it's almost like playing the role Sherlock Holmes, right? So in our clinic, we look for our patient, we look for him, we look for anything that we can find to help make the diagnosis. And the difference between us and other colleagues would be the ability to detect and to pick up very subtle hint to give out the to help with the diagnosis. And of course, after that, with the management of the patient as well. Okay. Anyone with any question with that aspect? I think one of the question I answered already, but one of the colleagues asked whether or not the use of ACE and lysozyme is still helpful. And so the answer is definitely yes. The correspondence is still quite high in this certain circumstances. Dr. Hin has done some of this work on this, and he has shown it some other previous presentation before. So definitely do test them, and then, but again, test them in patients whom you do feel that there is a high likelihood or there's a good possibility. If a patient just come in with just very simple nongranulomatous anterior uveitis that go away with one or twice type of treatment, and then with no other systemic finding, maybe that may not be the time that you need to test for that yet. On the other hand, some of the patients that Dr. Kidal showed with all this nodule and thing, that would be very important. So Sanjay, you're still ordering lysozyme and ACE, is that correct?
I'm still ordering them on patients. As you said, when there's a suspicion for it, I still am using the ACE and lysozyme, but predominantly we're using them as a supportive measure. I think it's, if for instance, the chest x-ray is negative and the ACE and lysozyme or the ACE is very high, it might push me to get a CAT scan at that point, or to try to look a little bit further in that case. But if it's by itself with no other findings, I'm less inclined to make a diagnosis of sarcoid just based on that test.
Yes, and usually is a combination of things. Just like many things we do, we look for more than one hint, and whether they are serologic or imaging biomarker, for example, it will be different and sort of that. So you definitely use as many hints as we can. There's a question here on more like a practical examination part. So I'm not sure David's gone already, but Sanjay can definitely answer this too. When we look for patient with scleritis, how do you use the red-free light to distinguish between conjunctival and deep scleral vessel?
Yes. So when this is definitely an important, I think, diagnostic tool. So in the clinic, when you're looking at the patient, oftentimes you look at a red eye and it's difficult to distinguish where the level of inflammation. So when you look with the slit lamp and you use the red-free filter, what that will do is it creates almost a black and white image, and it'll provide more three-dimensional relief of where the vessels are. Remember that in scleritis, oftentimes the vessels are more at sort of cross purposes to each other. There's more of a plexus formation there. Episcleral vessels tend to be more straight, radial, and conjunctival vessels will be more superficial. So when looking with the red-free filter, a lot of times that will allow us to, you'll actually get more of a three-dimensional image of the vessels, but also it allows you to distinguish those, whether it's truly a plexus or just the episcleral vessels crossing over with the conjunctival vessels as well.
Okay, there are two more questions, and then I'll try to answer this as well, and Sanjay can help as well. So the first question has to do with how you distinguish between sarcoid versus TB at both a granulomatosis disease, and that definitely a challenge on that aspect. For me, it has been very much depend quite a bit on the other characteristic of the patient. In certain part of the world and certain ethnic background, they're much more at risk. For example, when I was in Baltimore, I was there for about 15 years or so, and in my whole collection, there are probably about just 10 or so, 12 patients with TB-related uveitis. I have only been at Stanford for 3 years, and we're already in the collection of about 30 or so, or 35 patients with this, just because the number of immigrants from the various parts of the world, in particular in India, has come over here in the Silicon Valley area. So we see that. So it's very much depend on the and the endemic and also in the nature of the patient. Certainly, the group who have Sarcoidosis usually have one ethnic group, the group that have the TB on the other one as well. And so we are very much in terms of using those characteristics to make the diagnosis. Sanjay, have you noticed anything different in the LA area where you're at?
No, I would actually agree with you. I was surprised within the first few years of my coming here how many patients with very typical TB, serpiginous-like choroidopathy that I had seen here that I really hadn't seen as much when I was in New York, which was a little bit surprising. But I think when we're considering distinguishing these diseases, definitely demographics and history play a key role. There was a study that came out several years ago from LA County, USC. I think Dr. Narsingh Rao had authored that paper, trying to look and see if there were any characteristics specifically that could lead you to think that the patient is more likely to have tuberculous uveitis. And certainly it was in that paper, almost all those patients had immigrated from an endemic area. There was another paper from the Netherlands which showed that if patients had lived abroad in an endemic area for greater than 6 months, then there was a greater risk of them having tuberculous uveitis also among their uveitis patients.
Great. So we may not have enough time to discuss in more detail regarding the TB, but I want to mention again, if you look for a group called COTS, C-O-T-S, that stands for Collaborative Ocular Tuberculosis Study, COTS, you will see that we have published a number of manuscripts on this topic of treating tuberculosis, TB-associated uveitis, for example. Okay, so that will help you. And just like Dr. Kidal said, the demographic really help. And I think the last question I'm going to try to answer is that Dr. Price Cheng asked the question between TB and ill disease. So that's a fair question. So ill disease has to do with the retinal vasculitis, and so is TB. Both can cause vaso-occlusive retinal vasculitis, significant severe L. But remember that the diagnosis of ill is one of exclusion, meaning that you have to rule out other things first and no other etiology before you call it ill disease, when Dr. Henry Ills described about it. So how do you discuss about TB versus ill? Let's say if I'm lecturing in India, oftentimes I will have diagnosed and called it TB retinal vasculitis first before I call it ills, whereas in the certain part of the US, not in the Bay Area right now, but let's say in the Midwest, in Omaha, for example, it will be more likely of the other one, just because TB is rare. But you cannot call something ill until you have ruled out everything, including TB. So if you still have not checked for TB, and so you cannot really call it ill because you have not ruled out all the possibility yet. So that's how we think about it. Sanjay, any comments from you on that?
No, I wholeheartedly agree with everything that you just said.
Okay, so let us move now to the last lecture, and then we go to the case. And Sanjay, if you want to give